Good morning, dear colleagues. Unfortunately, we are in the last day of our Congress. We will discuss a lot today about the osteoarthritis of the shoulder. So I start my speech with etiology and general concepts for the management of glenohumeral osteoarthritis. Is a degenerative joint disease of the shoulder characterized by damage of the articular surfaces of the humeral and the glenoid. It is high incidence in the patients over 60 years old, women, and patients who had primary anterior dislocation. We can categorize in primary and secondary arthritis. The primary osteoarthritis causes DNA, and we have degenerative damage, thickening or absence of the cartilage, flattening osteophytes, chondral kyst formation, posterior humeral subluxation, and from part of the glenoid posterior where a subchondral kyst formation. The symptoms are shoulder pain, which worsening during the activity. We have limited range of motion, and of course, difficulty of the sleeping. From this physical exam, we had functional limitation of the range of motion, crepitus, scratching, and of course, we must carefully examine the function of the muscle of the rotator cuff. Radiographs give us a first idea for the grade of osteoarthritis, but CT scan give us a lot of information about the morphology of glenoid, and of course, we can do from that the operative tablating. MRIs give us a lot of information about the situation of the rotator cuff. The glenoid morphology is very useful when we want to do a surgical treatment. And the treatment starts with non-operative, with physical therapy, anti-inflammatory medicaments, and of course, in the articular ejection, corticoid ejection, biological, and hyaluronic acid, a topic that we talk later with Dr. Deligiorgis. At the operative treatment, we have total shoulder arthroplasty, anatomy arthroplasty, hemiarthroplasty, we abandon this technique, reverse shoulder arthroplasty, arthroscopic debridement, and CAM. Total shoulder arthroplasty, or anatomic arthroplasty, as we said, it has indication for intact rotator cuff, unresponsive in non-operative treatment, glenoid chondral wear, and posterior humeral head subluxation. A contraindication is the lack of the deltoid or rotator cuff function, the active infection, and sarcoarthroplasty. That is a tablet from the 2022 AUS registry, and we see how many primary diagnoses for anatomic shoulder arthroplasty procedure from 2050 to 2021. Hemiarthroplasty, as I said, is an abandoned technique. The indication were for younger patients, rheumatoid arthritis patients with irreparable rotator cuff, osteonecrosis with glenoid involvement. But the outcomes where early failure rate is not recommended. Reverse shoulder arthroplasty has indication for when we have osteoarthritis with irreparable rotator cuff, osteoarthritis of rheumatoid arthritis with significant glenoid pathology, rotator cuff arthropathy, failed arthroplasty revision, and complex fractures with good outcomes. As we see, the reverse shoulder arthroplasty, the number of the procedure increased with the time. In the right tablet, we have Norwegian shoulder arthroplasty registry, and at the other, we have a registry from AOS with a big part of the procedures with reverse shoulder arthroplasty. My talk was introduced for the next topics for this session. Thank you very much.
Thank you.